Okay, welcome back from break, and we're ready to get started again. We have this morning heard the perspectives of a general pediatric academician and a public health professional, and now it's time to hear a bit of a philosophy perspective on the issue of social determinants of health. And to help us do that, we have Dr. Erica Blacksher. Dr. Blacksher completed her PhD at the University of Virginia and then spent 2 years as a Robert Wood Johnson Health and Society Scholar at Columbia University. She's now an assistant professor in the Department of Bioethics and Humanities at the University of Washington, and her research examines the ethical and policy implications of the social determinants of and social inequalities in health. In particular, she's interested in those issues as they relate to U.S. healthcare reform, the developmental origins of and social inequalities in children's health, and theories of justice in public health and ethics and politics of health. So join me in welcoming Dr. Blacksher.
Thank you, Doug. Good morning, everyone. Call and response. Excellent. Well, before I begin with my formal, can everyone hear me? Great, good. That isn't always the case. And before I begin with my formal remarks, I have to say I had no idea that Dr. Bezrushka would be like the Chris Rock of academic presenters. So dial down your expectations for laughter. One of the reasons I'm up here is we have to dip into a little bit of social justice theory. It's, you know, that's dicey stuff, so I'm just warning you. Okay, let me make sure I know how this thing, uh-oh. What did I do? Okay. Oh, okay. All right, so yesterday, with the exception of Larry Churchill's remarks, our speakers focused on ethical issues related to health care and children's health and well-being. And this morning, we've widened our perspective to consider a broader array of social determinants of children's health. Things like income and education, neighborhood contexts and social networks, social capital, social support, and political power. We often refer to these as the non-medical determinants of health. Because the effect of these determinants on children are typically mediated by the family itself has begun to be talked about, considered, identified as a social determinant of children's health. So I want us just to keep that idea in mind because I want to talk in a similar way about the family as a social determinant of children's health. I want to talk about the family as a subject of social justice. So over the next now 29 minutes, we have three objectives. The first of which is I want to dig a little bit into the harms to children and children's futures. Dr. Bezrushka and Catherine did a nice job of laying all that out. I just want to reiterate and underscore a few points. Our second objective is to consider the ethical implications thereof. What do we make of this morally? And there again, I'll use the language of social justice. And then third, I want us to consider some implications for public policy. So to put this first objective in some context, let me say a bit more about the children I think are of utmost concern. I intend this list to be illustrative, not exhaustive. So we're talking about children living in contexts of poverty and near poverty, context of substance abuse and violence, children particularly from racial and ethnic minority groups, perhaps children living in foster care, perhaps children living who are incarcerated in juvenile detention or adult facilities. As Larry Churchill mentioned yesterday, I like to repeat these numbers whenever I have the opportunity because I find them so shameful. Some 21% of U.S. children live in poverty. And the U.S. government is known to have quite inadequate measures of poverty. So if you instead look at children living in low-income families, that number increases to 42%. So I'm going to talk about these contexts as exposures, and specifically as exposures to chronic adversity, chronic deprivation, chronic insecurity and instability. These exposures, again, as Dr. Mosley and Bezrushka laid out for us, can set in motion a cascade of biological and behavioral developmental patterns that can compromise children's physical and mental health, as well as key childhood and adolescent competencies and coping skills. So what I want to underscore is that early life deprivation and adversity can impact both children's health and their development. Researchers often use the term developmental health to capture this. So in the realm of health, just to quickly reiterate some of the points that Dr. Bezrushka make, we see disproportionate, in these populations, we see disproportionate rates of things like infant mortality, low birth weight, injury-related infant deaths, childhood injuries, type 2 diabetes, obesity, and so on. In the arena of development, we see pronounced differences in emotional development, temperament, social functioning, and cognitive capacity, things like literacy and numeracy. Now, the impact does not confine itself to childhood. Early life harms exhibit this longitudinal character, which is to say that they carry over into and compromise children's futures, both their future health and their future well-being. So the consequence of this, the result of this, is we see disproportionate incidence of chronic diseases and degenerative diseases in middle and late life, and detrimental effects on achievements in dimensions of well-being that impact opportunity. So things like educational attainment, employment, income attainment, social capital, social networks, even drilling down into something that seems very interior, one's sense of self-efficacy and self-mastery. One expert sums up the impact quite simply by saying children living in poverty face higher rates of just about any adverse health or social outcome. Let me use an example that's on many people's minds today to more concretely illustrate some of these harms. Childhood obesity afflicts as many as 1 in 3 socially disadvantaged children, with especially high rates among African American girls and among Hispanic and American Indian children of both genders. Obese children experience a disproportionate incidence of diabetes, asthma, cardiovascular conditions, sleep-disordered breathing, depression, high-risk behaviors, low self-esteem, and anxiety. In addition, here, to just illustrate the longitudinal effect, between 40 and 77% of obese children remain obese as adults, leading to elevated risks of heart disease, stroke, diabetes, osteoporosis, lower body disability, some types of cancer, and premature mortality more generally. In addition, to get at this sort of impact on future well-being and opportunity, childhood obesity adversely affects opportunities over the life course. Studies, for example, to illustrate this, studies controlling for intelligence show that obesity adversely influences levels of income and educational attainment. So what I want to underscore there is that it's just these harms impact not only children as children, but children's futures, their future well-being and liberty and opportunities. Now, many people assume that harms such as these warrant public action, public intervention. And we can attribute that to the seriousness of the harms, the vulnerability and the dependency of children, the negative impact on society more generally. So these types of harms tend to stand in for systematic moral argument to justify public action. When moral discourse is explicitly invoked, the language of social justice and children's rights are often used to frame the case. So I think it's important to ask, what does it mean to claim that social inequalities in children's health and well-being constitutes a social injustice? And secondly, what are the implications for seeking social justice on their behalf? So I want to explore that question with you. It's our second objective, and I'll try to make this dip into justice theory quick and painless. So let me begin with a caveat summed up well by the political philosopher Jean Hampton, sadly the late political philosopher Jean Hampton. She says, there has never been and is not now agreement on the nature of justice. Okay, so with that disclaimer in place, I'm going to make a bold move and suggest to you that modern conceptions of social justice tend to focus on 2 key ideas. One relates to what we might call distribution or redistribution, or what we might call distributive claims. The second relates to recognition, or what we might call recognitional claims. And when we transgress these ideas, we can call them harms of maldistribution and harms of misrecognition. Okay. So distributive claims refer to the idea that everyone deserves a fair share of some set of important goods. It's a seemingly simple idea that's enormously complex. It contains three questions that modern theorists of justice have to answer. The first of which is, well, which goods? Which goods should be subject to considerations of justice? The second of which is, well, how much of these goods constitutes a fair share? And third, well, who counts as everyone? Do we really mean all persons? And of course, this is no surprise. Different theorists answer these questions really differently. But I'm going to make some generalizations, and I'm going to do so quickly just to sort of advance our collective learning here. So when trying to distill down which goods, of course, philosophers and theorists are concerned, well, which are really central to being human, central to human welfare, central to well-being, central to flourishing. And one way to frame the goods is in terms of outcomes. Okay, so I'm going to give you the example of Madison Powers and Ruth Faden, who've articulated a theory of social justice with particular sort of concern about public health and health policy. And they've identified what they call 6 essential dimensions of well-being, things like health, personal security, respect, reasoning, and so on, that they think it is the job of justice to secure a sufficient level of. Now notice that these are outcomes. The second way of framing the goods is in terms of opportunities or resources and means. And the prominent example there is John Rawls' notion of primary social goods, things like civil liberties and political rights and income and wealth and fair equality of opportunity for education and employment and so on, social bases of self-respect. And notice that these are means and resources for good outcomes, but they're not outcomes themselves. Now, had we the time, I could give you other examples. But we don't. But it's worth noting that only recently has health been identified as the sort of good, the sort of outcome that might be subject to principles of justice, as we've learned more and more about the degree to which the distribution of health is in fact subject to our collective choices about our social institutions, our political processes, our political institutions. So in a similar way, the social determinants of health can be conceived of as the goods to be distributed when those goods are conceived of, framed as opportunities and means and resources. So now to the second question, the how much question. There again, there are a variety of answers to that question. One of which might be strict equality. Well, just the idea that goods should be allocated equally. Now, the moral concern that underpins that view is that inequality per se is bad. The position is vulnerable to a number of critiques that we don't have time in these remarks to review. This principle often gives way to an alternative view, another standard of allocation, if you will, that prioritizes those who are worse off. The moral concern that underpins the priority view or the priority principle is that the conditions and circumstances of those who are worse off are simply morally unacceptable. This principle is not concerned with inequality per se, even though in lifting those who are improving the conditions of those who are worse off, we may in fact limit or narrow inequality. We also may not, by the way. It's an empirical question of whether any particular policy does that. And this prioritarian view has different versions. There's the difference principle, there's the sufficiency principle, they're different, and we can talk about those should they be different. But I want to emphasize the difference between strict equality and a priority principle. Then the third question, well, who counts? I mean, if the basic distributive claim is that all persons deserve a fair share of some set of important goods, do we literally mean all persons everywhere? Are we committed to a global view, a cosmopolitan view? Or do we mean something more like, well, all and only persons who live in wealthy developed nations? Or do we mean something like only our compatriots, that is, only people who share our political boundaries? And if we mean that, does that mean we don't mean to include those people who live among us but who are not citizens? So there's one final idea we need to touch on that's relevant to this idea of redistribution to distributive claims, and that idea is social causation. It's operating implicitly in distributive claims, and it's linked to the idea of responsibility. So only those harms or inequalities or deficits that are caused by social arrangements can be subject to distributive principles. Evidence of systematic social inequalities in health, i.e. those differences in health associated with social class, race and ethnicities and other markers of disadvantage, is evidence enough for many people that social arrangements exert considerable influence over health outcomes, and they conclude that social structures are indeed responsible for these harms, these social inequalities in health. Nonetheless, the question remains highly debated, not just in philosophical circles, but also in policy circles. At least in part because some people look to data that show that health behaviors make a non-trivial contribution to health outcomes. So these are some of the key considerations that relate to the idea of redistribution. The second sort of claim that I mentioned, that often also travels under the banner of social justice, refers to what some call recognition. Now, recognition refers to the idea that all persons deserve an equal opportunity to participate in public life, in social life. At bottom, this claim is about the respect owed to non-dominant groups, groups that are marginalized, stigmatized, or otherwise subject to demeaning treatment based on some shared characteristic, whether it be their skin color, their gender, their religion, their sexual orientation, so on. Any number of isms, racism, sexism, homophobism, represent classic violations of recognition respect. Now, one might think that recognition respect can be achieved for these groups by meeting distributive goals. That is, if all persons have a fair share of some important set of goods, all will receive the basic respect they deserve. These other isms will fade away. But the case has been made, and I think quite persuasively, that one, distributive goals themselves are simply inadequate to address this other sort of serious moral claim. And second, and more insidiously and interestingly, distributive goals, the pursuit of a fair distribution, can actually be pursued in ways that actually reproduce and reinforce the stigmatized status of non-dominant groups, and in that way can inflict harms of misrecognition. Thus, some theorists contend that the pursuit of social justice today must be concerned not only with a fair distribution of goods, but also with recognition, which is to say, ending relations of domination and establishing relations of equality. So, with these admittedly very quick and dirty explanations in place, let's get back to our primary concern. What does it mean to claim that social inequalities in children's health constitute an injustice, and what are the implications for seeking social justice on their behalf? Well, so let me just quickly suggest the following 3 points. With regard to the first question, what does it mean to claim that these inequalities in children's health are unjust? Well, first, children cannot be held responsible for the health deficits they endure, or for the health behaviors they develop, or for the socioeconomic circumstances that place them at risk. They simply cannot be deemed responsible agents because they're not yet fully developed agents, at least while they are young, and as we have seen, health deficits are set in motion very, very early in life. Second, these harms can be traced to a maldistribution of resources or social determinants and result in a maldistribution of very important goods. Whether you frame those goods as outcomes, like health and other important dimensions of well-being, or opportunities, the children's development for future opportunities. And third, the last point I'd make on this question is that these harms can be traced also to forms of misrecognition. Minority children are disproportionately represented among the ranks of children with health deficits, and these harms can be attributed not only to poverty, but also to racism and other forms of invidious treatment. So if it is correct, and that's a question, that the currency of social justice today relates to ideas about redistribution and recognition centrally, then I think there's no doubt that social inequalities in children's health constitute an inexcusable injustice. That's not to say that there aren't really difficult questions that could be posed about, well, precisely which children should be considered the worst off, whether all inequalities in children's health are unacceptable. These questions relate to the how much question, which in my view is one of the more difficult distributive questions to answer. But we're going to leave that question for another day, or at least for the panel. So let me move to the second question I posed about the implications for seeking social justice on children's behalf. The other way to ask the question is, what sort of public policies and health interventions must we pursue? And just as importantly, how ought they to be pursued? What I want to suggest is that efforts to remedy and prevent these harms to children will need to treat the family as a subject of social justice. There are, of course, poor children who lack families for whom this prescription does not apply. The moral status and treatment of these children should be of concern to all of us, and there are experts in this room, I'm looking at Dr. Maureen Kelly, who can speak extensively and eloquently about these cases. But many of the children we're concerned about do, in fact, have families. They have a parent, or parents, or a grandparent, or a caregiver in some form who is trying to provide for, perhaps struggling to provide for, and to create and maintain a safe environment for their children. And as we've discussed at length this morning, the health and well-being of children is inextricably bound up with the well-being and the agency of those contexts that they're born into. And the context I want to focus on is the context of the family, those who are rearing them. The family provides not only material support that keeps children sheltered, clothed, and fed, but also the nurturance and love they need to become emotionally healthy, thriving human beings. Moreover, the family can act as a translator of the world. What I mean to say is the family can amplify or buffer the effects of hardship. The family can pass on traditions and practices that can strengthen or weaken a child's spirit and resolve. All of which is to say is that the family exerts a profound and basic influence on children's life chances. The upshot of which is that we must think about the family as a subject of social justice. It's interesting just to note that in Rawls' original iteration of the theory of justice, he equivocated on this matter until the feminists went after him, and then he put the family squarely within what he called the basic structure that should be subject to principles of justice, and he never quite got that resolved, what that meant. So I think this fact, the profound influence of the family, has implications for public policy. And I think the implications are twofold. I think that means that our collective efforts, our policy efforts, our institutional efforts will need to promote both structural equality among families as well as parental capacity within families. Now, by structural equality, I'm talking about the structural equality relates primarily to redistributive policies, policies that can reduce the ever-growing gap between the haves and the have-nots, policies that can support families' material capacity to rear their children in contexts of stability and safety. By parental capacity, what I'm referring to there are more targeted interventions that seek to enable parenting practices that need to be very responsive to particular contexts, particular communities and cultures in which parents are doing the rearing. For reasons I'll discuss in a minute, recognition and respect, that second kind of justice claim, is critical in the development of these sorts of interventions. Now, one way to further distinguish these two approaches, these two types of reform, if you will, is that the former acts on the material and the social environment, what we might call structural changes. The latter is more targeted with the specific goal of behavioral change. Now, structural change can have behavioral effects as well, but we can talk about that later because that's actually more complicated. And I think for a number of reasons that health equity for children cannot be achieved in the absence of a health strategy that pursues both of these goals in tandem. So let me use the case of childhood obesity to just illustrate this claim. You know, it's interesting, I give you these little pointers, but I don't give you any detail, which may be frustrating to you all, but it's what the PowerPoint experts say we're supposed to do, just sort of give you a teaser. So, Okay, so experts have identified a range of social factors and actors that have contributed to the rise of childhood obesity, and which would need to be addressed if we were going to try to stem the rise. They include things like, this is again an illustrative list, not an inclusive, exhaustive list. Food advertising campaigns. Okay, these induce children to desire and to ask for high nutrient, low calorie food. The more children are exposed to television, the data show the more effective these campaigns are, and low income children are disproportionately exposed to TV. Now, we can talk about why that is. It's not because low income parents are bad parents, it's for a whole host of reasons that impede their ability to not put children in front of televisions. Neighborhoods. Neighborhoods where disadvantaged children grow up and play have higher rates of crime, gang activity, often lack safe places for children to play, are oversaturated with fast food restaurants, and often lack grocers that sell good, healthy food. Schools. Schools often make available the purchase of unregulated foods through vending machines and other venues, which generate significant revenue that resource-poor schools are particularly reliant on. In addition, things have changed, like mandatory physical education. We've gotten so ramped up with, testing students' math and reading and science and all of that, that mandatory physical education is exceedingly rare. And school location is also a factor. It may preclude walking to school or biking to school, or at least doing so safely. Income. Income is implicated across all of these factors. Low-income families tend to have far fewer structured recreational activities for their children, tend to live in unsafe neighborhoods, tend to rely more on television for recreation, sometimes to keep their children off out of unsafe parks and off unsafe streets. They may have limited time and money to purchase and prepare healthy meals, and so on and so forth. So any number of structural policies, can be brought to bear on the problem. Policies that ban the food advertisers from targeting children, improve the built environment features of the neighborhood, increase policing to make a neighborhood safe, transfer cash to poor families in one form or another, perhaps vouchers to move to safe neighborhoods, ban vending machines from schools, on and on. Some of these things are being implemented. But even in this scenario, parenting behaviors remain sort of a critical factor. They mediate a child's relationship to this broader universe. Parents stock the house with food, feed their children, turn the television on or off, model behaviors related to all sorts of important things that include things like diet and exercise, self-regulation. It strikes me as a matter of just sort of plain common sense to develop a child welfare strategy that treats structural and behavioral changes in interrelated goals. Yet, if you look at least policy history in the United States, what you'll find is that these goals have been often pitted against one another or treated in isolation. What you'll find are policies that try to fortify the material conditions in which children are reared, or policies focused on parental behavior, which are often demeaning and punitive. Now, there are likely any number of reasons for this. I would suggest it's often a function of competing explanations for disparities in children's health, which can then be used in a selective way to serve one or another ideological agenda. The case of childhood obesity is actually illustrative again here. I cannot tell you how many times I have witnessed talking heads talking about childhood obesity, only to hear them sort of say, no, it's a parent's responsibility, no, it's a social responsibility. I'm always puzzled by this debate because it strikes me that it's both. We have to make structural societal changes that enable parents to rear their children in safe places with healthy behaviors and all of that. So there's a risk, though, here, and I have a couple of minutes to address it. This twofold strategy, the latter one, these targeted interventions, they're fraught with ethical risks, and I alluded to this earlier. Specifically, these targeted interventions run the risk of reinforcing or reproducing the marginalized and stigmatized status of disadvantaged groups and alienating them from participation in whatever sort of reform effort is underway. This is the case in part because these programs can be seen as or experienced as an indictment of parenting behavior. These programs can be seen as blaming the victim. I don't think that has to be the case. So let me just conclude with a word about that. If I understand this clock correctly, I have about 1 minute left. Is that right? Anybody? Okay. So this is why recognition and respect is really critical in the development of these interventions. And one way that such respect can be demonstrated, and here I'll be very quick and vague, and maybe we can talk about more of this in the panel, is to view these families as, sorry about that, is to view these families as partners in the development of such programs and partners in change, to tap what they know about the problems they face and the concerns they have to build the programs and interventions in response to their knowledge and their input. I was struck yesterday at the end of the day when we heard from the families, and the overwhelming message at the end of that was, talk to us. We're living these lives. And I would just underscore what they so more eloquently said. Now, this is not a novel suggestion. It's a very old idea, this idea of community participation in health. It goes all the way back, to my knowledge, to the early 60s. Today, we often talk about community-based participation in research, or CBPR. That's another form of the idea. It's enormously difficult to implement and to do well. But it is, I think, our moral imperative to try. So with that, let me conclude, and thank you all for your time and attention.